Welcome back, guys. Again, so this module is bit of a tough one. Like personally, I don't like this much because it's more of memory and very less concepts. The inflammatory mediators, the cytokines, the histamine, the serotonin, the preformed, the cell-derived arachidonic acid pathway. We're going to discuss about that. The concept actually is bit less. It's more of memory, but unfortunately, you have to know this in order to extrapolate. Whenever we require the inflammatory mediators, we should have everything in our hand. We should have everything in our mind so that we can apply. This is very important from an from an extrapolation point of view in future when we come to different disorders, as well as from an MCQ point of view, because few of them, most of the faculties in medical colleges love it. I don't know for what reason. They want you to know which prostaglandin causes what. It's needed, not much in depth. Yes, it's needed to understand few treatment options, few drug interactions as well. So yeah, with a little bit of effort, we'll try and read all those things, right? Put a smile on your face and let's start. So what we're going to start here in this chapter, we're going to see is about inflammatory mediators. We're going to see about inflammatory mediators. So we saw about acute inflammation. We saw about the diseases in acute inflammation. What we are going to see is what causes that acute inflammation. In the selectin and the integrin things, we saw that cytokines help, interleukins help, right? What are those? What are the group? Even the endothelial gap formation, we saw about histamine, where it is formed from, what do they do? That's what is entire this module about, right? So when I have inflammatory mediators, we are going to divide inflammatory mediators into broad categories. We're going to divide them into cellular mediators and plasma derived mediators. One is cell derived, other one is plasma derived. So plasma derived in the sense these molecules are already in the plasma. I'm going to just activate few of them and I'm going to result in inflammation. That's what is plasma derived. The best example is complement system. Right? They are plasma proteins. In active form, I activate it and make sure the inflammation cascade goes away. Right? So plasma derived mediators are main two types. One, your complement proteins, which you already know. Another one is kinin. Kinin is a bridge between your clotting cascade as well as your inflammatory cascade, right? Kinin system helps in both of them. When we come to cell-derived mediators, again we are going to bifurcate them. We're going to divide them into preformed mediators. Okay. Other one, they are newly synthesized mediators. That's what we're going to divide them into. Preformed in the sense, let's take neutrophils. In neutrophils especially, we have lysozymes, we have granules. The contents are already there. My MPO is already there, myeloperoxidase. We just now saw in phagocytosis. It's already there. I'm going to use them. What are the newly synthesized? Prostaglandins are not there generally. What happens is when I'm going to have an inflammation, the arachidonic acid gets modified into prostaglandin, leukotrienes. They are newly synthesized mediators. Preformed mediators and newly synthesized mediators. In preformed mediators, we are going to read about histamine. We're going to read about serotonin. Okay. We're going to read about lysosomal enzymes as well. We're going to read about lysosomal enzymes and one more thing, neuropeptides. And also we're going to read about preformed mediators. Fine. Though they don't come exactly under it, we're going to read them under that. Okay. Neuropeptides. These are the preformed mediators. So what are the newly synthesized mediators? Newly synthesized mediators, majority of the one is the arachidonic acid pathway. The arachidonic acid pathway, I'm just writing AA metabolites, which includes all your prostaglandins, leukotrienes, lipoxins, everything. Both pro as well as anti-inflammatory arachidonic acid pathway gives me. Next, we are also going to read about nitric oxide. Nitric oxide is synthesized, right? And also platelet activating factor, PAF, right? Platelet activating factor and cytokines. I will not go in depth about cytokines for the only reason they are much more detailedly explained in microbiology. I'm sure you must have known that. Right? Cytokines, we will require cytokines when we read about inflammation, chronic inflammation, and different disorders. I'm not just going to give a list of them. You don't want me to give a list of them, right? It's just names and just going to be the function. I'm just going to say where all I can help you in understanding these mediators. So we're going to divide them into cellular and plasma derived. And in cellular we have these, and in plasma derived we have these. Now first we'll go to cellular, then we'll go to the plasma derived. The cellular mediators, As we wrote first, we'll be seeing about the preformed mediators already. So first we'll go to histamine. So histamine, as the name says, it's a protein which has to be synthesized from an amino acid. It's going to be histidine. Histamine, histidine. It's synthesized from histidine. It originates from histidine. Histidine. Okay. Okay, it originates from histidine. So the richest source of this histamine is going to be, so we have them in multiple tissues, multiple cells can have them. The richest source of histamine is from mast cells. Mast cells are the richest source of histamine, which means tissue basophils. So blood basophils also will have them. Platelets also can have them, but the richest source is going to be mast cells. They're also seen in platelets, can also produce them. Blood basophil can also produce them, but the richest source is obviously my mast cells. Fine? That's about histamine. So if we know about histamine, I need to know the function of histamine as well. What will be the function of histamine? One we already know. We saw in the endothelial gap formation, endothelial contraction, increase in vascular permeability. Histamine mainly helps in vasodilatation. It helps in vasodilatation and increase in permeability. Okay, it's permeability. Increase in permeability of the blood vessels of the endothelium by forming endothelial gap junction. Okay, and also helps in bronchoconstriction. Histamine is going to help in bronchoconstriction. Fine. You might read them based on this function. When I'm going to antagonize histamine, what is going to happen? You read them in pharmacology. It's linked. Everything is interrelated. So we know this. We know the function. If I'm going to block or if I'm going to activate, what will be the symptoms? What will be the outcome? That's what we'll be reading in pathology as well as in pharmacology. Fine. Next. The second preformed mediator was serotonin. Serotonin comes from, it's also called as 5-hydroxytryptamine, right? It's 5-hydroxytryptamine, 5-HT, 5-hydroxytryptamine. And as we go with histamine, we need to know the richest source of serotonin as well. The richest source of serotonin is platelets. Okay, they are also seen in enterochromaffin cells. In the GIT, enterochromaffin cells also contribute to serotonin, right? Enterochromaffin cells. I want you to remember this for the only reason. When we read about the disease of enterochromaffin cells, tumor of enterochromaffin cells called as carcinoid, we'll also read about carcinoid syndrome, where this product is going to be in excess, and all the symptoms of serotonin excess will be seen in the carcinoid syndrome. So for that, I need to know the function of serotonin, which is almost similar to my histidine. Vasodilatation, increase in vascular permeability, and bronchoconstriction, right? Same thing, I'm just writing as histamine, so that you not memorize them. The only thing is the richest source will vary, and obviously the chemical component also varies. Third biggest one are the lysosomal enzymes or lysosomal granules. See, lysosomal granules are important. I would say that instead of memorizing a lot, there are primary granules, secondary granules, and tertiary granules. It's a bit difficult to memorize them. I would say it's not required for you to memorize them. Memorize the entire lot. I'll just tell you which are all practically important for me, either in inflammation chapter or anywhere in pathology and medicine. Try to remember them at least, right? So in lysosomal granules, they can be seen in neutrophils, and almost every granulocyte can be seen in macrophage as well. Wherever there is lysosome, these granules will be present, right? So lysosomal granules, we are going to divide them into primary granule, secondary granule, and tertiary granule. In the primary granule, they are also known as azurophilic granule. Fine. It's because of the staining property, right? They are called as azurophilic granule. Okay. They are the most destructive. When I'm going to have an infection, the one which is going to protect me first is my primary granule, right? They are the most destructive granules, which is going to help me to protect from the infection. So when I say most destructive granules, I want you to remember the contents. Some of them, not all. See, the most destructive granule, when we saw inflammation chapter, the acute inflammation process, we saw about the macrophage trying to destroy my bacteria, destroying by producing HOCl. Which enzyme was helping that? MPO. So MPO is the content of primary granule, first one. Next, in the same place, when we read about diapedesis, right? Diapedesis is nothing but my neutrophil is going to come outside of the blood vessel to the extracellular space. That time I said that I need PCAM, that's one molecule, plus I need one more thing which is going to be my collagenase. I need to destroy them with the help of collagenase. So I require that for acute inflammation. Collagenase is also a content of this. Non-specific collagenase. When I say non-specific collagenase here, I am going to write a specific collagenase in the secondary granule. It's implied. Type 4 collagenase will be in the secondary granule. That helped me actually in diapedesis, right? Next. Elastase. I wanted to remember this for the only purpose. I'll just put a square here. When we are going to read about emphysema, smoking related disease, that's where my elastase is going to help. Smoking related, this gets activated and is going to destroy my entire lung elastic tissue and causes emphysema, where this granule is going to be of help. Then we have cathepsins. Cathepsin G to be specific. Okay, this I'll be requiring when we are going to read about neoplasia chapter. In neoplasia, these guys will come. Not actually in neutrophil, it will be coming in the macrophage segment, right? Cathepsin and also your phospholipase A2. So phospholipase A2 is very, very essential for your arachidonic acid pathway. That also is required for me. So whatever is here, they are part and parcel of inflammation. They are the most destructive. They are the primary ones, right? That's about primary granule. There are quite a few of them. You can remember this because it's related with the disease or some process. Secondary granules, what do I see them? Secondary granules are called as specific granules. I want you to write this. I want you to remember this for the only reason. When I say specific granules, in the first primary granule, we saw something called as non-specific collagenase. So one of the content is already known. I will have a specific collagenase here. So one of the content here will be a specific or type 4 collagenase. Okay, I'll have a type 4 collagenase. I have gelatinase, matrix metalloproteinases. One of them is gelatinase. They all come from this. These two guys you will be requiring when we read neoplasia chapter as well. In particular, when we read about the metastasis path of neoplasia. I want you to link that with this. When you read the neoplasia chapter, when you see the neoplasia chapter, I want you to remember this as well. Fine? Next we'll have lactoferrin. And one more thing, vitamin B12 binding protein. Okay, vitamin B12 binding protein. Why I put this, this is a bit important. I put a Q there. It's a bit important. It was asked as an MCQ previously. That's not the important part. And lysosomal granules has vitamin B12 binding protein. Right? So whenever I have abnormality in lysosomal granules or whenever I have an abnormal increase in WBC count, vitamin B12 level can be altered. This was used in the diagnosis previously for polycythemia and CML. Not now. We have much more specific tests now. The reason why B12 gets altered in chronic myeloproliferative neoplasm is it's seen in the secondary granules of the lysosomes. Fine. Then tertiary granules. Okay. Tertiary granules main role is in chemotaxis. It helps in chemotaxis. The granule content, I am sure you may not remember about the granule contents. It's non-specific. It also has gelatinase. Nothing much to remember. Just remember its main role is in chemotactic pathway, right? That's about the lysosomal granules. In the cell-derived things, we have seen histamine, we have seen serotonin, and we have seen lysosomal granules. The fourth one, what you're going to see is, you're going to see about neuropeptides, right? Neuropeptides. Okay, neuropeptides. The examples of neuropeptides, I'm sure you must have read at least one thing in your physiology called a substance P. Substance P has some feedback mechanism, some role in one of the pain pathways in physiology, right? So substance P is a neuropeptide. Fine. And also a neurokinin. Neurokinin A and substance P are neuropeptides. Substance P, if I said it's involved in some pathway. When it's going to be involved in some pathway in physiology, they must be intricately involved in neural fibers. Stimulus releases substance P. So it's going to be seen in It's seen in nerve fibers, especially in the GIT and lung. In lung and GIT, I'm going to have them nerve fibers, and it's not a rocket science. When I have neuropeptides, it has to be something to do with the neurons, right? Okay, fine. It's also seen in my leukocyte as well. So, what is the function or mechanism of action? Pain. Pain signal transduction is the most important action for these neuropeptides. Apart from that, you're going to have the same non-specific vascular changes here as well. It will also help in increasing vascular permeability. Okay. I want you to remember especially here pain. Substance P, P stands for pain. I want you to remember that. And neuropeptides, they are stored in the neurons, nerve fibers, as well as a little bit in leukocytes as well, right? That's about the cell-derived mediators. Cell-derived preformed mediators. And we have the chunk of the newly synthesized mediators. That's your arachidonic acid pathway. Very important from an MCQ point of view. Not only in pathology, it will be related to pharmacology. Not only that, when you go to obstetrics and gynecology also, few of the prostaglandins play a very important role in obstetrics and gynecology as well. So it's linked everywhere. Prostaglandin is very, very important. The commonly used drug, Dolo 650, paracetamol, plays along with prostaglandins. Aspirin plays along with prostaglandins, right? So we have to know about the newly synthesized mediators as well. Fine. So of the newly synthesized mediators, we saw the arachidonic acid metabolites, nitric oxide, and platelet activating factor, right? First, we'll see about nitric oxide. Fine. One of the important question, where it's originating from. We saw histamine, histidine, right? Like that, nitric oxide is going to be synthesized from arginine. It's synthesized from arginine. Okay. And obviously, I need an enzyme that's called as a nitric oxide synthase. NOS, nitric oxide synthase. We have an inducible nitric oxide synthase. There are different types of nitric oxide synthase that will be dealt in detail when you go to pharmacology, right? You have nitric oxide synthase. With the help of nitric oxide synthase and the primary raw material is arginine, I'm going to have nitric oxide. Nitric oxide has various functions. They're going to help in vasodilatation. Okay. They help in vasodilatation. They're going to help me in. They play a major role in platelets. It's an anti-aggregator of platelet, right? They're going to help in platelet. Wait 1 second. They're going to help in aggregation of platelets. This is an anti-aggregator. It's going to inhibit the platelet aggregation, right? They're going to inhibit platelet aggregation. So it's lost of words, right? You're going to inhibit the platelet aggregation. You're going to help in the vasodilatation as well. And they also have a very important antimicrobial activity. When we saw free radicals, in the aging place we saw free radicals, we saw OH minus, we saw superoxide free radical, we saw H2O2, we saw HOCl. Here nitric oxide will also be involved and is going to produce a free radical which helps in the microbial destruction. It's a microbicidal action. It produces free radical. It produces peroxynitrite free radical. It's very important. This helps in peroxynitrite free radical, which helps in the destruction of microbes. Not the main one, but yes, it does a very important role in the destruction of microbes. I want you to remember nitric acid. We will use nitric oxide when we are going to come to sickle cell anemia. It is involved in the process of sickling as well. Nitric oxide is an important one. You need to know the functions, especially this function, and the arginine, which is the raw material, that also is required for us to remember. And that's the first one. And cytokines, as I said, you will read with microbiology. Fine. Then go to our major guy, who is our. Before going to our major guy, we'll finish one more one, tiny one, PAF, platelet activating factor. Right? We'll see about platelet activating factor. Platelet activating factor is one of the most potent inflammatory mediators. They are much more potent than histamine. Though I may have less quantity, but when they come, they're going to definitely do the action. They are very potent. Though even in tiny quantities, they're going to be very, very potent. As the name says, it's platelet activating factor. So it's going to activate platelets. So it will inhibit aggregation or stimulate aggregation. Obviously, my function will be, it's going to increase platelet aggregation. As the name says, platelet activating factor is going to increase the platelet aggregation. Fine. And they cause vasoconstriction and bronchoconstriction. They are going to cause both vasoconstriction as well as bronchoconstriction. See, till now, whatever we saw, histamine, serotonin, both of them are vasodilators. Platelet activating factor is going to be vasoconstrictor. But platelet activating factor can do both vasoconstriction as well as vasodilatation. Where this becomes important from an MCQ point of view is when you're going to read about, when you have an INICD exam, where you're going to have multiple options. Action of platelet activating factor can be both vasoconstriction, but at low doses, they do vasodilatation, same like histamine, and increase the vascular permeability as well. Fine. They also increase the vascular permeability as well. I want you to remember this for the only reason you won't expect that one single substance is going to do both exactly opposite actions. So you may not write them as a correct answer when it comes in MCQ. But platelet activating factor does both. Normally vasoconstriction, when it's in low doses, it's going to do vasodilatation and increase in vascular permeability, right? That's about platelet activating factor. Then we'll come to the biggest group, arachidonic acid metabolites. We're going to read about the arachidonic acid metabolites. Fine. So arachidonic acid metabolites, so where do I see arachidonic acid? It's going to be seen in the plasma membrane. Plasma membrane has it. So when I have a plasma membrane, the phospholipids in the plasma membrane, it's derived from them, right? It's newly formed with the help of phospholipase A2, that's also primary granule content. With the help of that, it's going to produce arachidonic acid. Okay. So now this arachidonic acid is kind of my important person, because from this arachidonic acid, I'm going to have different pathways. Cyclooxygenase pathway, lipooxygenase pathway, we'll have prostaglandins, we have lipoxins, and lots of them. From this arachidonic acid, these metabolites which are formed are, when I have a cyclooxygenase acting on the arachidonic acid, I'm just writing cyclooxygenase pathway. I'll be forming prostaglandins, prostacyclins, and thromboxanes. Three of them, right? You're seeing prostaglandins, prostacyclin. See, it's based on the structure, that's all. Though the action will be different, and thromboxane A2. We'll read about thromboxane A2 furthermore when we come to platelet disorders. The aggregation of platelets, it helps in few of the actions of the platelets, fine? That's about the cyclooxygenase pathway. Not only cyclooxygenase pathway, arachidonic acid also can have lipooxygenase pathway. It's also involved in the lipooxygenase pathway as well. Okay? So in the lipooxygenase pathway, it can form leukotrienes. One of the leukotrienes we read already, leukotriene B4, which is involved in chemotaxis. We'll see other of leukotrienes as well, right? We will have leukotriene, and also we'll have lipoxin. Lipoxin is not actually an pro-inflammatory; it's like an anti-inflammatory. In the termination of inflammation, we saw lipoxins, right? It's going to help me to terminate inflammation, not an exactly pro-inflammatory mediator, right? Next, we'll also have a few other things which are not exactly the important ones. The important ones are my prostaglandins and leukotrienes. Other metabolites of arachidonic acid, we'll have when an cytochrome P450 epoxygenase acts on it. Not much important for me. I'll have EET and HETE. HETE stands for hydroxyecosotetraenoic acid. Right? Not much important for me, so I'm not just going to explain about it. We'll just ignore it. We'll just know that it's also formed, right? HET, if you want the expansion, it's hydroxy ecosa tetraenoic acid. Fine. The HET one. Not much required for us. If you know about prostaglandins and leukotrienes, more than enough. See, if you're in second year also, don't worry. Inflammatory mediators entirely could be maximum a short answer. You can write 4-5 pages easily. Once you're second year, you know pharmacology as well. So put a COX inhibitor, you'll tell what will happen. Put a LOX inhibitor, you'll tell what will happen. You can tell about each and every one individually, right? So these are the pathways in which arachidonic acid can be metabolized. Based on that, I'm going to have different actions, right? We'll see about little bit about each of the prostaglandins, the function, where it differs, where it has a synergistic action, lipoxygenase leukotrienes function, as well as what are lipoxins. Fine. We'll go to the prostaglandins. First and the most important one is prostaglandins. So what happens exactly after we just saw that arachidonic acid pathway, it directly gives to prostaglandins with the help of cyclooxygenase. So I'm going to have an intermediate mediator. I'm just writing arachidonic acid. With the help of the enzyme cyclooxygenase, this is your COX. The first prostaglandin is going to be formed as PGG2. That will be the first prostaglandin formed. After that, I'll have PGH2. They are all like rings, chemical mediators. That's all. PGG2, PGH2. From PGH2, what I'll have is I can have prostacyclin. PGI2 is prostacyclin. Prostacyclin. They'll have a completely different function totally. We'll have thromboxane A2. I'm writing it as TXA2, thromboxane A2. And then we'll have the rest of the prostaglandins. From PGH2, we're going to have prostacyclin, we'll have thromboxane A2 and the rest of the prostaglandin, which stands for your PGD2, PGE2 and PGF2. Actually it's F2 alpha, E2 alpha and D2 alpha, but I'm just writing PGE2, D2 and F2. All of them are formed. Prostacyclin and thromboxane, these two kind of acts have an opposite action. Regarding platelets, they have an opposite action generally. So prostacyclin, the function of prostacyclin is going to be, it's going to inhibit platelet aggregation. It's like your nitric oxide inhibits platelet aggregation. And I said it's opposite, right? So thromboxane function is going to be, it will accelerate platelet aggregation, like your platelet activating factor. It's going to increase your platelet aggregation. Fine. Then regarding blood vessels, prostacyclin acts as a vasodilator and thromboxane acts as obviously as a vasoconstrictor. They are exactly opposite functions, right? Platelet activating factor and thromboxane A2 almost has a similar effect. In normal doses, they are also vasoconstrictors and they also increase platelet aggregation. Prostacyclin or PGI2 has the exactly opposite function, right? Then we'll come to PGD2 and PGE2. PGD2 and E2, they cause again vasodilatation and increase in vascular permeability. Okay. This is common for both PGD2 and PGE2. But PGD2, in addition to this, they also are a powerful chemoattractant for neutrophils. They help in chemoattractant for neutrophils. Okay. Unfortunately, this entire module is a bit monotonous because it's more of information and than of logic. I have to remember this. You have to remember this. Only then, when I'm coming to an inflammation, you can understand few things much better. Right? Discuss with your friends. Do whatever you can. But I want you to remember this forever. When you know the chemical, when you know the action, you will know when I block something, what will be the effect. You need not memorize pharmacology. Something should be read, right? To understand maths, you need to memorize tables. Just like that. Just remember like that and just memorize. There are very few places I'll ask you to memorize. the entire pathology. One of them is this. CD markers also I'll not ask you to memorize, except for a few. I'll not ask you to memorize. I'll tell you a logical explanation for that. But this, I cannot say the logical explanation. If I have to say the logical explanation, I have to go to the chemical structure. Even more irritating, right? So just memorize this chapter now. And PGF2 alpha. PGF2 alpha has an important role during pregnancy as well, because these act on the uterine smooth muscle. So PGF2 alpha causes contraction of smooth muscles, includes both uterus as well as the bronchus. So this will be connected to your pregnancy as well. So I'm going to contract, this is going to help in the contraction of the bronchus as well as uterine smooth muscle. So when I'm going to have an analog which increases function, there will be a different action. When I'm going to block it, I'll have a different action. So I want you to remember this so that you can compare it when you come to uterotonic agents in pharmacology, right? It's going to act on both uterus as well as bronchus. Fine. And they also help in the constriction. It constricts smaller arterioles, again because of smooth muscle only. Small arterioles, they do constrict, right? They're going to help in the constriction of smaller arterioles. Okay. Prostaglandins are also an important constituent of fever. I'm sure you know that, right? Prostaglandins may play a major role in fever formation. We'll read fever and which prostaglandin helps in fever when we come to our systemic methods of inflammation, where we'll see about fever and other systemic effects of inflammation, right? As of now, we will have just these informations with prostaglandins. I'm just dividing them into bits and pieces so that I don't overload you much with information, so that you don't get saturated. I'm sure already you'll be saturated. I am saturated because there's too much of information for me. But I want you to remember, discuss with your friends, that's the best way to remember, or write it down in a paper, take a photo, keep as a mobile wallpaper for 1 week. You'll definitely remember. 100 times you open your mobile per day, right? Minimum. Read and close, you'll definitely remember. That's about my cyclooxygenase pathway. So what's about lipooxygenase pathway? So in lipooxygenase pathway, we had two metabolites, leukotrienes and lipoxygens, right? So in lipooxygenase pathway, so we have two metabolites. The reason why we have two metabolites is, so when we have arachidonic acid, I'm going to have two types of lipooxygenases. I'm going to have 5 lipooxygenase. I'm writing LOX for lipooxygenase. I have 12 lipooxygenase. When this enzyme acts on the arachidonic acid, I'm going to get an leukotriene. The chemical component which produces leukotrienes. In leukotriene, we're going to divide them into two major groups. One we already saw in chemotaxis. The leukotriene B4 is going to be involved in chemotaxis, which we already saw, right? The rest of the one, we're going to have leukotriene C4, leukotriene D4, and leukotriene E4. Right? Actually, leukotriene A4 is the mother of all. The leukotriene here will be leukotriene A4. When 5 lipoxygenase acts, I'll have a leukotriene A4, like your PGG2 and PGH2. From that, I'll have a bifurcation of B4 for chemotaxis, and the C4, D4, E4, they have almost similar functions. They're going to help in vasoconstriction. They'll also help in increase in vascular permeability, and also they help in bronchoconstriction. Okay. But these leukotriene C4, D4, E4, they are very much involved in anaphylaxis, bronchoconstriction, increase in vascular permeability, which means you'll have an edema in the bronchial muscles, the bronchial region. So it helps in it is one of the important mediators in anaphylaxis. So we call them as slow reacting substance of anaphylaxis, or the entire group, right? Slow reacting substance of anaphylaxis. So it's SRSA. It's a known abbreviation. Slow reacting substance of anaphylaxis, right? The entire group is going to help in the pathogens of anaphylaxis. Fine. Next, the other one was 12 lipoxygenase. We saw about 5. We have to see about the 12 lipoxygenase as well. So 12 lipoxygenase pathway, it's going to result in, majorly it's going to give us lipoxins. Lipoxin is anti-inflammatory. It's not a pro-inflammatory substance. It's going to anti-inflammatory. It's going to help in the stoppage of inflammation, the termination of inflammation, right? They are anti-inflammatory. So they have various anti-inflammatory roles. One of the important one, they inhibit the neutrophil chemotaxis. That's what I said. Once the job is done, once the neutrophil is able to kill the entire bacteria, it's going to send information to my blood vessel. Don't send me more people. Don't send more neutrophil. So I have to give an information. Stop the neutrophil exudation and chemotaxis. They're going to inhibit neutrophil chemotaxis. Fine. They'll inhibit neutrophil chemotaxis. Next, they also inhibit NK T cell activity. Right? So I'm going to inhibit my neutrophils. I'm going to stop the inflammation. So once inflammation is stopped, what is the next logical step? The next logical step is to formation of healing process. I have to initiate the healing process. The guy which is going to help me in healing process, macrophage. We'll see them in the chronic inflammation. So here, I need macrophage. I need more amount of macrophage so that healing process goes smoothly. So lipoxins stops inflammation and helps in the activation of macrophage so that my healing becomes smooth, right? So the next function is going to activate macrophages, right? It is going to activate macrophages. Two roles. My neutrophils is there. This is my inflammation site. My neutrophils came here, engulfed the bacteria, destroyed every bacteria. So these neutrophils are there. So once macrophage is activated, this macrophage comes and engulfs my neutrophils, changes, becomes activated macrophage and helps in wound healing. That we'll see in healing chapter. So lipoxins has two roles. Stop the inflammation, activate the healing process, right? That's about the arachidonic acid metabolites. We saw about prostaglandins, we saw about lipoxins as well. Right? So we have kind of covered the cell-derived mediators, right? We have covered your histamine, serotonin, your neuropeptides, your difficult granules. We have also covered your newly synthesized mediators, nitric oxide, right? We saw about platelet activating factor, cytokines we didn't see, and we also saw about arachidonic acid mediators. Next one is plasma-derived mediators. Plasma-derived mediators, we saw about two important things: complement proteins and your kinin system, right? Kinin system is a bridge between your clotting cascade as well as an inflammatory cascade. Especially one of the most important thing in the kinin system is bradykinin, right? That's what we're going to see. And also complement system, you do know better than me. There's one entire chapter of complement in your microbiology as well, right? So first we'll go to kinin system. So kinin system is an intermediate between coagulation cascade as well as my inflammatory system. So what happens exactly in kinin system is the person is going to spearhead the kinin pathways, factor 12 or your Higman factor. So when it's factor 12, I have that's Higman factor or contact factor. There are many different names for it. So with the help of factor 12, when it's getting activated, becomes factor 12A. This factor 12A is going to convert pre-kallikrein, which is a precursor form of kallikrein, which is an inactive kallikrein. So it converts pre-kallikrein into active kallikrein. So this kallikrein is going to again convert one more important thing, high molecular weight kininogen. It's also a protein seen in the plasma. See, all the main differences, all these proteins are there in the plasma always. Clotting factor is always there in inactive form. But prostaglandin is not always there. They are newly synthesized. The main difference. That's why you have cell-derived and plasma-derived. We have high molecular HMW kininogen. We have high molecular weight kininogen. This will be converted to our important bradykinin with the help of your kallikrein. Right? We'll have bradykinin with the help of kallikrein. So here, one of the most important mediator in my kinin system is bradykinin. So we have to know what bradykinin exactly does. So bradykinin, that's an important one in our kinin system. It helps in vasodilatation, like any other, most of the inflammatory mediators, as well as increase in vascular permeability. Bradykinin has a very important role in pain, right? It also helps in pain. We had substance P, which helped in pain. Next one is going to be bradykinin, which also plays an important role in pain mediation, right? That's about this kinin system. It's a link between your coagulation cascade as well as this, right? I'm not going to go in detail about complement cascade, right? Because complement cascade, you already guys know. I'll just give you an overview of complement cascade. I just want you to remember one here because that is related to glomerulonephritis. I just want you to remember that so that when we come to glomerulonephritis, you should not get stuck, right? So in complement cascade, what you're going to see in complement cascade or the complement system is all of them are protein synthesized in the liver. Right? They are protein synthesized in the liver. All of them are proteins inside the liver. So complement cascade has three groups of activation. You know the classical complement cascade, the alternate complement cascade. That's what I want you to remember. And also you have the lectin system, right? You have classical complement cascade or the classical pathway. We have alternate pathway. And we have lectin. Lectin I'm not writing separately because lectin kind of feeds onto my classical pathway, right? Kind of feeds on my classical pathway. So this classical pathway, it's going to get activated by my antigen antibody complex. I'm just drawing the cascade, the complement cascade. And here comes my lectin, the mannose binding lectin. So the lectin pathway kind of feeds onto my classical system. So what these both does is, it's going to convert C1, an inactive complement cascade, to C1A. Whenever you have A, that's an active complement cascade, right? This is an active complement protein. So C1A will convert C4 and C2 into active C4 and active C2. It will form, when it's going to get activated, the uniqueness of C2 and C4 is I'll have C2A, C2B, C4A, C4B. Similarly, what happens is, when it's going to be activated, I'm going to lose C4A and I'm going to lose the 2B fragment. I'll lose the 2B fragment and C4A fragment. So what I have is C4B and 2A. See, this will be lost. So I'll have a complement, active form of complement comprising of 4B and 2A. This guy is an C3 convertase. This guy is classical pathway C3 convertase. We'll have alternate pathway C3 convertase, different one. Just give us a little bit of space, we'll write them separately. The alternate pathway is going to be based on C3. I want you to remember this because when you come to glomerulonephritis, especially when you come to glomerulonephritis, we're going to read about a type of glomerulonephritis called a C3 glomerulonephritis. They are entirely based on alternate pathway of activation of complement. C3 glomerulonephritis, because C3 is the main thing in that glomerulonephritis. So C3 is the main thing here. And I also want you to remember alternate complement cascade is also activated with help of immunoglobulin A. That also is required in my glomerulonephritis. So C3 becomes C3A and C3B. So here I'm going to have one more factor as well, called as factor B. The factor B gets activated by factor D. All of them are proteins. See, this B, this D, all the proteins will be involved in glomerulonephritis. I want you to remember this, how this happens, so that our glomerulonephritis understanding becomes superb, right? So once these two combine, I'm going to have C3B, BB. This is also my C3 convertase, but that is alternate complement pathway C3 convertase. So I have these both C3 convertase. It's going to combine and do only one thing. It's going to convert my C3 into active C3, right? It's going to convert more C3 into an active C3. So this C3 will again convert which will bind to my existing C3 convertase, which help me in the conversion of C5 to an active C5, C5b. C5a again will be lost. Fine. So when C5b comes, your C6 to 9 molecules join to C5b. C6 to 9 molecules join to C5b and they form C5b to 9. This is my final product. This is the final product, is the one which is going to destroy everything. This I'm going to call it as membrane attack complex. Right? Membrane attack complex, or called as MAC. This is the guy which is going to destroy my entire inflammatory cells or your bacteria or something. It's going to destroy every membrane, human as well as bacterial. So it helps me in progression of the inflammation. It's an inflammatory mediator. I want you to remember all of them because this becomes extremely important. When I'm going to alter something in the complement cascade, I may have a disease, right? I may have a disease. I'll have inhibitors of complement cascade. When they are not present, I'll have a disease. When MAC is too much, I'll have a disease. We'll read them in different hematology as well as in systemic pathology. For that, I need this base. Okay, that's about inflammatory mediators. I know this module is extremely tough, full of information. Please write it down. I want you to memorize somehow. It's wrong from a teacher's point of view to say it's memorized, but I want you to memorize so that you will not have a hiccup later on in understanding a disease. See, because pathology is everything is about understanding. If you fail to understand, you'll be lost. I have a handful of disease based on inflammatory mediators. Either remember this chapter or memorize all the diseases. It's better to remember this chapter, right? Memorize this chapter so that many diseases in future will become a cakewalk for all of us, right? It's the only chapter in the entire pathology I'll say memorize and mug up. Otherwise, I'll never use it up. I don't like that. But yes, I need some base for me to understand future diseases, right? So try your best to memorize it. Keep smiling. Bye-bye. Have a big cup of coffee mug. Take a big mug of coffee because you must have drained of energy. So am I. I'll go have a coffee. You also go and have a coffee. Come back to the next video. Till then, bye-bye from Dr. Ranjit. Bye-bye.